A very good evening, one and all. On behalf of Lupin, myself, Rohit Nair, Vice President, welcome you all for the session. Lupin is committed to serving patients with world-class medicines and, of course, in disseminating scientific updates among medical fraternity. Thanks for joining for today's session on hyperlipidemia management with first-in-class siRNA therapy, INCLISIRAN. This revolutionary molecule gives exceptional benefits. And to discuss that, we have eminent speakers like Dr. Nakul Sinha from Lucknow and Dr. Kamal Sharma from Ahmedabad, along with Dr. Michael Korean, who is the Chief Investigator in Victorian Initiative Trial. I now request Dr. Pradeep Mate to share brief introduction about rich experience of our respected panel doctors and set the context of the meeting. Over to you, Dr. Pradeep.
Thank you, Rohit. So welcome you all for this webinar on management of hyperlipidemia with INCLISIRAN. So I'm glad to welcome today's moderator of the sessions, Dr. Kamal Sharma. Sir is present working as Associate Professor of Cardiology at BJ Medical College and UN Mehta Institute of Cardiology and Research Centers at Ahmedabad, and consultant interventional cardiologist at Sal Hospital, Ahmedabad, having a rich experience and area of interest in interventional cardiology, and has conducted many drugs and device trials as well. So we welcome Dr. Kamal Sharma. Our today's faculty is Dr. Nakul Sinha. Sir is former Professor Head Cardiology, SGPGI, Lucknow, and presently a Chairman Cardiology, Max Hospital, Lucknow. Sir, having more than 30 years of experience in cardiology, having more than 150 research publications to Sir's credit, and many editorial book chapter to Sir. So we welcome you, Sir, you as well. And today's speaker, international speakers, Dr. Michael Koren. We welcome Dr. Michael Koren. Sir is a practicing cardiologist and Chief Executive Officer at Joconsil Center of Clinical Research, which conducts the clinical trials at 8 locations at Florida. He is principal investigators and conducted more than 500 clinical trials on dyslipidemia, cardiovascular disease, and heart failure. Many research articles as published in peer-reviewed journals like the American College of Cardiology, New England Journal of Medicine, and Lancet by Professor Koren. So we welcome you all the speakers, faculty, and moderator. Before we proceed to the programs, I would request today's moderator, Dr. Kamal Sharma, to set the context. So over to you, Dr. Kamal Sharma, sir.
Hi, good evening, everyone, and welcome each and every one of you. I welcome warmly Professor Nakul Sinha and Dr. Michael Koren. It's going to be a good discussion, and we look forward to a huge learning experience because I think we yet to reach the zenith or the peak of lipid-lowering therapies, and we now have an armamentarium, INCLISIRAN, which is a therapy which is being touted as what is called as lipid vaccine. Ever since the mRNA silencing has been there and mRNA vaccines have been making noise at the horizon since the COVID era, this therapy has also got public attention in terms of a therapy that can modulate lipid management, especially in patients if we can document CV outcome reduction. So though evolocumab and other PCSK9 inhibitors have already been there, INCLISIRAN therapy is promising because of the duration and also is awaiting CV outcome data sets that we intend to hear and get enlightened about with Dr. Michael Koren and also from Dr. Nakul Sinha. So with this context and setting and with the concept that I often talk about, that rule of averages is not normal. What we defined averages as normal is no more the truth. Probably the event rate of getting zero is something that we probably need to learn from primates or aborigines whose LDLs have been often below 55 for so many long years. So guidelines though have been bringing LDL down. With this context, I would now hand over the session to the Lupin team and also invite Dr. Professor Nakul Sinha to talk about Indian perspective on INCLISIRAN and therapy. Over to you, Dr. Nakul Sinha.
Thank you, Dr. Kamal. And very good morning to Dr. Koren. Lipids have always been a matter of great debate also. Why? Because, there have been periods when there has been a lot of controversy raised about whether lipids are that important or they are being overhyped. But I think, as Dr. Kamal said, that the balance of evidence has always favored that lower the better and faster the better, especially in acute coronary syndrome. So let's spend a few minutes for the Indian perspective, not only because, as usual, Indians are supposed to be different in many ways, but also because the Indian conditions demand a more sort of inquisitive approach, a balanced approach, a cost-effective approach. And I'm sure these things are going to be discussed in the panel discussion. These facts have always been touted and more or less have been proven over the last 20, 30 years with different studies, that we Indians are more prone to develop earlier CAD, younger patients, younger population is more affected. People may debate what are the risk factors, but the fact remains. And most important, we do not see that those high LDLs and even the average LDL level is on a lower platform compared to the Western populations. But yet, as a paradox, we are experiencing premature CAD and high mortality. Of course, a very worrisome situation. The differences, if we just come to the lipid profile, obviously are lower baseline LDL, higher TG and lower HDL. In fact, we have also studied isolated low HDL in Indian population. And that is again a segment which needs a particular fresher approach. But certainly, along with this combination, we have elevated apolipoprotein B and slightly higher levels of lipoprotein small a. So now this is a cauldron where the effect is known, the reasons, the interactions may not be that clear, but the effect is known. But what is perhaps important to understand, that the treatment of lowering LDL works as good as in any other population. That is what we have come to the conclusion over the past many years. If we just like to see that, with high dose statins, we have achieved a lot. So is there a need for further decline of LDL and lowering the LDL mortality? So as we can see, the mortality rates from CV disease, especially in the Western segment, plateaued out and then went down with the use of high dose statins, which was a very widespread adoption. But later on, there was a stagnation. So something was missing. And even if we see in different population studies spread over different continents, especially the famous Da Vinci study or those by Santorini and Zuin et al., even the Indian study shows that not more than 20% of patients post-ACS are achieving the designated or required or recommended LDL levels. So that's quite worrisome. And of course, the concept of residual risk is also there. No matter what you do, what drugs you use, the residual risk is still significant. Therefore, something else needs to be done. That's absolutely important. Another very sort of important concept is that it's not only the magnitude of LDL, but the duration of exposure which impact the risk. And in fact, there are growing evidences that the plaque burden and the plaque composition both depend, and their vulnerability to rupture causing an MI depend on the magnitude and duration of LDL cholesterol exposure. We know it's not hard to imagine why there is poor control of LDL despite such good therapies available. Because of adherence, availability, cost, and sometimes a careless attitude that fine, I've been doing okay for a couple of months. Why do I need to take more medications? Moreover, poor adherence causes the LDL variability, which is another concept which has come up in the last 5 or 6 years. That if there is an up and down passage of the LDL, that is harmful. And if there is a downward trend which is going on and on, then there is an incremental benefit, an incremental reduction in mortality, which is added every year. So LDL variability has been shown to be an independent predictor of cardiovascular events. And as you can see in the graph, the red line indicates an upward trend, visit to visit LDL, going up, coming down, going up, coming down. While if there is a downward trend, there is a clear advantage in the mortality figures. Indian guidelines. Now, this time we have been really aggressive and brusque. Not mincing any words, we want a very low LDL and as quickly as possible, especially if there has been an ACS. So, we have made a special category of extremely high risk individual, where there is a diagnosed CAD, ACS, recurrent episodes despite polyvascular involvement and multi-drug therapy, and possibly added or capped with an elevated LP small a. Lesser than that will be a very high risk, then a high risk category. So you can see that the majority of patients, by virtue of either being a diabetic or having recurrent episodes or having multiple factors or even just having a poor adherence to therapy, all of them are going to fall in high risk categories. And therefore, for these very high risk and extremely high risk categories, the recommendation here is below 50 and even in some cases below 40 or 30 milligram per deciliter. So that will come to around less than 1 millimole. As such, the algorithm is very simple. You choose the medication. Now, in which group, which medication you choose, I am looking forward to the panel discussion because I have a few suggestions and a few queries. But once you have chosen high dose statin, then it's quite logical and easy to add ezetimibe if you want a faster reduction and a greater reduction. Check it 4 weeks. If you're to your desired result, continue the treatment. If not, you can try bempedoic acid if there is an element of economics which is involved and the patient cannot afford costlier injectable treatment. If the bempedoic acid works in the next 4 to 8 weeks, well and good. If it doesn't, you have to sort of depend upon the PCSK9 inhibitors or the new molecule that's INCLISIRAN. That invariably to the tune of 80 to 87% will get down your LDL to your desired goal within 12 weeks, and it will maintain it at that. That's also important. There won't be a variability, there won't be an up and down, because if you are missing a few doses of statins, you can go up. So that is not there if you are using the PCSK9 inhibitors. So as said by Dr. Kamal Sharma, INCLISIRAN is the first LDL lowering small interfering RNA therapy. And the gist is that it gets washed out from the blood within 48 hours because it has done its job by then. Because by interfering with the process of RNA, the target RNA is subjected to degradation and conjugated, and it is only done in the liver because there is a specific greater hepatic uptake. And therefore, the reduction of LDL cholesterol level is not only fast, is not only intense, but it is maintained for a long period of time. Quickly going through the trials available, I'm sure they are going to be discussed in more detail by our guest speaker. But the Orion 10 was testing this molecule in established atherosclerotic disease. So you can say there was a 52% reduction, 54% sustained reduction. So we are getting both facets of the treatment well online. In patients with heterozygous familial hypercholesterolemia, which is quite a difficult thing. I mean, homozygous is perhaps the peak, but heterozygous is not that uncommon. Here also, you have nearly a 50% effectivity and sustainability of 40%. Additionally, non-HDL cholesterol and ApoB levels are also favorably affected. So that's, if anything, is a bonus. Extended follow-up, because we need to be sure about the efficacy, safety, and its pan applicability. Whether any groups are there which are not responding, not to my knowledge at the present moment of time. So extended follow-up was seen in the Orion 8 trial, which was basically a extended follow-up of 3 years from 4 previous trials, the Orion 3, 9, 10, and 11, all in different populations. And the Orion 18, this was specifically for Asian patients, because otherwise the sort of proportion of Asian patients studies was not that high. But this also showed a similar, encouraging, and rather a comforting and satisfying result. The suggested benefits of in CV outcomes are sort of seen and more of extrapolated. But yes, there is no reason to believe that we will not have those suggested benefits being translated to real benefits in terms of reduction in MI, reduction in vascular events, fewer MACE, and better more reduction in mortality. The pooled analysis of the 9, 10, and 11 trial. Otherwise, the 20% patients who were reaching threshold, that has been pushed to nearly 80% on an average. So that's very good news in terms of the armamentarium that we have now to tackle this LDL elevation. So this is the comprehensive clinical trial program. Dr. Koren will again sort of throw more light upon it. For the prevention trials, we have Victorion 1, 2, and Victorion plaque prevention trials. So we'll hear more about this. And I'm sure with this body of knowledge, with this comprehensive 360-degree planned program of testing of INCLISIRAN in different subgroups at different stages of the disease, we are going to have a very solid data and lots of answers to even the questions that we want to discuss. So dose and administration is very easy. It's just a subcutaneous injection. The first one has to be repeated at 3 months, and then it's a 6-monthly dose. But let me tell you, whatever limited experience that we have, there are many patients who even at 3 months or 6 months without the repeat injection are showing the same reduction in LDL, which is more than 70%. Advantages. Well, there cannot be any drug defaults because it's injectable and it's infrequent. Later on, it will come to only a 6-monthly injection. Very safe, very specific action, only very few cases of local site allergic reactions which are easily tackled. So amongst the existing lipid-lowering therapies, inclisiran has an advantage with whichever way you want to see in terms of frequency of dosing, the extent of LDL reduction, and the near absence of side effects. Because the standard intolerance can sometimes be a real problem. In guidelines, it's now well represented, and we need to see sort of more subgroups where and when inclisiran may need to be introduced in the treatment. So what does all this data mean to us? Intense, sustained lowering is possible with very infrequent maintenance dosing schedule, well tolerated, and practically free of side effects, possibly the closest we can reach to a near perfect treatment. Thank you very much for a patient hearing, and I'll stop sharing. So
Thank you, Dr. Nakul
Dr.
Sinha.
Koren can sort of go ahead with his exposition. Thank you.
Now I invite Dr. Koren for his talk.
Okay. Can you folks see the screen?
Not yet.
Not.
Let's see, share screen, presentation, share.
Yeah,
Yes.
it's there.
Okay. Do you see the full screen?
Yes,
Yes.
sir. Yes.
Okay.
Can you move the slides, sir? You can able to move the slides?
Yeah, I can advance the slide.
Yeah, perfect.
Everybody sees my screen now? We're all good? You can see my screen?
Yes, sir. Yes. Please continue.
Okay. All right. Well, thank you very much for inviting me to this meeting. Particularly excited about this for a number of reasons that I'll share with you in a second. But I want to start by saying that I want to really amplify the comments of Dr. Sinha and Dr. Sharma and make some really important points that we've stalled in terms of progressing cardiovascular disease prevention. And I'm going to show you some data. And then I'm going to specifically share with you some of my experiences in India, as well as talking about a study called the Victorian Initiate study, which was an important strategy study that I was the lead investigator and designed the protocol. We presented this study just this past year and this past spring at the American College of Cardiology meeting in 2024 with simultaneous publications. And I think it is an extraordinarily important study to understand from the standpoint of the implementation of a lipid strategy. These show my disclosures, and again, I was part of a number of different studies in the inclisiran development. The current owner of the product of inclisiran in the United States and around the world, as I understand, is Novartis. But this is a drug that was originally developed by the Medicines Company, and I've been involved with the development of the drug, for over 7 years. So I've been very involved in developing these compounds over the course of time. So I want to talk a little bit about my experience in India. I assume that this picture is familiar to the audience. And I gave a wonderful tour. I loved your country, a beautiful country with a lot of really engaged physicians. And we had fabulous scientific discussions during a lecture tour that I gave about 5 years ago. I did 10 lectures while I was in India and enjoyed every one of them. But the other thing that was interesting for me is that I got introduced to the fast form of cricket while I was there. And I found that people in India are obsessed with this sport. It was on TV constantly. And I learned about Virat Kohli, who we call the I guess, the Michael Jordan of India in terms of his popularity and the fact that he is such a hero to the population there. And he's sort of the face, as I understand it, especially internationally, of the fast and furious form of cricket. And he had a quote that I loved, and I created a slide around it, that he took a brash and aggressive approach to his sport. And I think we can apply this to the treatment of hypercholesterolemia, and particularly in relationship to the Victorian Initiate study, which actually was not a study specifically of inclisiran. It was actually a study of the strategy of a brash and aggressive approach, or a fast and furious approach to treatment of hypercholesterolemia versus usual care. And as I drill into details, I think you'll understand why this is so important, thinking about it as a strategy study rather than just as a clinical trial to look at a drug. So for a little bit more background, there's some both good news and bad news historically when we look at cardiovascular disease. So the rate of cardiovascular disease deaths actually dropped fairly dramatically in the United States and around the world between 1980 and 2010. And this slide shows you some of the details of that. So if you look at either all cardiovascular disease or specifically coronary heart disease, you can see that there's either a 26% drop or a 34% drop in the decade between 2000 and 2010. And this drop corresponded with very aggressive promotion of statins in the United States and other parts of the world. And I don't think it's a coincidence. I think that during this period of time, physicians were going to educational sessions. Industry was talking about the wonders of getting cholesterol down with these new class of drugs at the time of statins. And we were looking at outcome studies, one after another, showing this consistent effect that lower LDL cholesterol resulted in fewer heart attacks and strokes and other complications. So that was the good news. But the news that wasn't quite as good was that despite this incredible progress, there was still a high residual risk. And in 2010, coronary vascular disease was still the number one cause of death in the United States, and still accounted for 1 of 3 deaths overall in the US and many other parts of the world. But the other thing that was really interesting, and I learned more about this during my lecture tour in India, was that when I gave this tour in 2018, India had already exceeded the United States in terms of cardiovascular death rates. And in India, as the country became industrialized, we saw that there was a movement towards greater and greater coronary vascular disease. And unfortunately, in both India and in the United States, we really have not seen progress in reducing cardiovascular disease rates compared to 2012 and 2015, which in the US was the time period when we saw probably the best progress and the lowest risk. You're probably all very familiar with this concept that as India has become more urbanized, and even today, when you look at the rural areas versus the urban areas, you see a great uptick in the coronary heart disease burden. And these are the actual numbers, which are, they were actually staggering numbers to me when I first learned about them during my lecture tour in India in 2018. And we just highlighted what the total number of deaths were in 2000 in India, comparing the urban areas and the rural areas, and how that more than doubled between the year 2000 and the year 2015. Really quite a staggering bit of information. And again, I looked up the data specifically for this talk, and we found that there really has not been any progress in India, unfortunately, in reducing these numbers compared to 2015. So now I'm going to jump into the Victorian Initiate study, and I'm going to start by saying that this study is what we call a pragmatic clinical trial. And I'm going to highlight some of the features of this trial that make it a unique trial, and actually a bit different than the standard clinical trial that you may be reading about or have heard about over the years. So again, just to emphasize some of the points already made, there's extensive support showing that lowering LDL cholesterol, particularly aggressive lowering of LDL cholesterol, improves cardiovascular outcomes. And guidelines around the world have demonstrated that there is a benefit to getting that LDL below 70 in most high-risk patients, and now, quite frankly, below 55 in the extremely high-risk patients. And even Dr. Sinha introduced the concept of getting LDL below 40, which I would be supportive of. In the United States, most patients with atherosclerotic cardiovascular disease fail to reach their goals for a number of factors. Dr. Sinha mentioned all this, but the word that we use here to describe that is clinical inertia. And there's a lot of elements to clinical inertia, but a simple example is somebody comes into your exam room, you tell them, wow, you had a heart attack 2 years ago and your LDL is still 80. That's not where it should be. And the patient will say, oh, doc, I forgot my medicine a couple of times. I left it on the cruise ship during a vacation. Or, yeah, we had 3 weddings and I've not been up to snuff with my diet. So please give me more time to get this thing under control. And as physicians, we try to please our patients. We don't necessarily want to be too brash. And we say, okay, well, see if you can do a little bit better next time. But what happens is that this clinical inertia results in very few patients actually reaching their goal. And as mentioned, when we look at surveys of how many patients actually achieve their goal with really good reason to get their LDL down, it's only about 20% that get there in the United States and elsewhere. As mentioned, inclisiran is a first-in-class small interfering RNA, which inhibits the hepatic production of PCSK9 and increases the LDL receptor expression for LDL clearance. And as mentioned, twice-yearly inclisiran is remarkably effective, easy-to-use medication that'll get most patients to an LDL of 50% less. It works either by itself or, in most cases, with statins. And this particular study, called Victorian Initiate, evaluated the strategy, again, I emphasize the word strategy, of using inclisiran first, which means we immediately used inclisiran once people signed up for a clinical trial. And these are folks that had a history of coronary disease, had an LDL greater than 70 despite receiving maximum tolerated statin therapy. And we wanted to see if giving them a shot right away would result in better outcomes over the next year compared to usual care. So this was a randomized study. People were identified. If they agreed to participate in the research protocol, they came into a research office, and we randomized them again to inclisiran first or usual care. And then those that got randomized to inclisiran first would immediately get a shot, and those that were in usual care would go back to their treating physicians. And other than giving them the shot, everything else was handled in this study by treating physicians, not the research center. And one of the reasons we did that is that we didn't want to introduce the bias of having people do much better in the study just because they were being seen in a research center. So this slide now shows the study schema. And again, we did screening, invited them in. They were randomized, and the screening was visit 1. The randomization occurred at visit 2. And the population who we invited were people who were greater than 18 years old, people who had an LDL of greater than 70 milligrams per deciliter, or non-HDL cholesterol greater than 100 milligrams per deciliter, and fasting triglycerides of less than 500. Again, patients had to be receiving maximally tolerated statin therapy or documented statin intolerance for them to be considered for the study. What we did in this particular study is we selected 45 different sites around the United States. This was a US-based study. We tried to get a diverse setting of people by looking for sites that were in urban areas, looking for sites that were treating our military veterans, looking for sites that were in suburban areas and even rural areas. We had a long discussion about medical insurance status. My preference was that all the patients in the study would have health insurance. And the reason I thought this was important is that if you're in the usual care arm and don't get the inclisiran first, I wanted to make sure that people had the resources to receive treatment, whatever their treating doctor thought was required and necessary under the circumstances. We had a little bit of discussion about this, but we ended up stratifying based on this. And as I'll show you, 97% of the patients actually had health insurance. So this kind of became a moot issue. The other thing that was important is that there was a study physician who was involved in the oversight, but the actual decision about lipid management was left to primary treating physicians who are either the cardiologist or the endocrinologist, or whoever else was treating this particular patient. And we asked all the physicians, and we reminded all the patients that we encouraged you to follow the AHA, American Heart Association, and the American College of Cardiology multi-society treatment guidelines, which are pretty aggressive. Most of these patients had an aggressive target of less than 55 milligrams per deciliter on the LDL cholesterol. And then the schema shows you when patients came for visits, and the end of study visit, which was approximately at 1 year, was the primary endpoint of the study. So specifically, we wanted to see the percent change in LDL cholesterol from baseline to day 330. And we also wanted to see the discontinuation rate of statin therapy, defined as no statin use, for greater than 30 days before end of the study visit. And this was very important because there was some concern that using an advanced lipid therapy may discourage patients from using statins. So we want to look at that specifically, make sure that statin use wasn't changed, or if it was changed, we wanted to figure out how much it was changed once patients were introduced to inclisiran in the aggressive arm of the study. The key secondary endpoints of the study were the proportion of patients who met pre-specified LDL goals at day 330 and safety analyses that were conducted through end of study visits. One of the interesting things about this study is that the study started right before inclisiran was approved in the United States. But shortly after the start of the study and during most of the recruitment, inclisiran was available to patients, and patients in the usual care arm could get inclisiran if their treating physician decided to do that, but they didn't get it necessarily immediately. This slide shows the baseline demographics of the study. You can see the median age was 66 or 68 years. Interestingly, about a third of the patients were female, and we felt pretty good about that. We wanted to have a diverse patient population. You can see the percentages in the parentheses. We had about 12 to 13% African-American patients, which is proportionate to the population in the United States. And we had about 14 to 70% Hispanic patients, which again is proportionate to the United States population. As mentioned, there was a lot of focus on whether or not patients had health insurance. So we want to make sure they had resources if they were in the usual care arm. And it turned out that 97% of patients did in fact have health insurance. We looked at this from the standpoint of income level and education. And we found that the majority of patients were working class people who had an income level in the United States of less than or equal to $50,000 a year. And about half of the patients had higher education greater than high school. The vast majority event had prior cardiovascular disease events, and the other patients had multiple risk factors, including diabetes. And interestingly, a quarter of the population reported some degree of statin intolerance. And the baseline level of LDL, and again, remember, this is a very high-risk population, was 97 milligrams per deciliter. And remember, guidelines were recommending us getting down to 55 milligrams per deciliter. So in general, these patients were well above what guidelines would recommend for LDL control. And this slide shows the co-primary endpoints of the study, which was LDL cholesterol. This looks at all time points, but by reminder, the key time point was at approximately 1 year, exactly 330 days after the patients were randomized. And obviously, all the patients started out with about the same level. And at the 90-day mark, you can see there was extremely little movement of the LDL cholesterol in patients that were in the usual care arm. Whereas in the inclisiran arm, there was already a 58% reduction in LDL within the first 3 months. Quite impressive difference. Over time, maybe the usual care patients needed a little bit more time to reach their goal. But you can see that things moved extremely slowly over the course of the year. And after 1 year of patients being in a clinical trial, we're reminding them over and over and at each visit that their LDL cholesterol is not where they should be. There was only a 7% reduction in LDL cholesterol. So this is really the main take-home message of the study, is that in usual care, despite having resources, people don't get to their LDL goal and have a relatively modest reduction in their LDL cholesterol during the course of the next year. Whereas people in the inclisiran first arm who were treated immediately have a quick and sustained reduction in their LDL cholesterol. The other thing that I mentioned that was a point of concern turned out to be really interesting. And we found that there was actually more statin discontinuation in the usual care arm than there was in the inclisiran first arm. So for whatever reasons, this concept that using an advanced therapy would make people lazy or make people less likely to use their statins turned out not to be true. Is that using the more aggressive concepts actually kept people on their statins at a greater percentage of the time than people who were in the usual care arm. And this slide will show you the patient level data for every person in the study. And the main take-home lesson here is that these dashed lines at the bottom are the levels where people should be. This is the 70 milligram per deciliter level. This is the 55 milligram per deciliter. And you can see that in the inclisiran first arm, there's a big movement in the blue to most of the patients getting below these threshold levels. But unfortunately, in the usual care arm, the patients are just not getting where they should be. And there's relatively few people that get to their goal, particularly the more aggressive goal. In fact, if you look at the more aggressive goal of 55 milligrams per deciliter, fewer than 10% of the population got to that level. This slide looks at some of the key secondary endpoints, and the one that I alluded to was the changes in background lipid-lowering therapy. So as I mentioned, when you look at statins, which is in here comparing the two blue lines, you can see that there was a little drop-off of statin use in the inclisiran first line, but there was actually a much larger drop-off in statin use in the usual care arm. And you can see that still there were some patients in both arms that had no additional lipid-lowering therapy. Of course, in the inclisiran first arm, this was in addition to inclisiran. But in the usual care arm, this was in addition to nothing, unfortunately. And then the concept of using statin combination therapy was, again, rarely used. And this would include drugs like bempedoic acid or ezetimibe, which were rarely used in the in the usual care arm. And interesting, the advanced lipid therapies, which were available to most of the patients in usual care, were only used in 2.5% of patients in the usual care arm. So here we're seeing the actual data supporting this unfortunate concept of the fact that in clinical practice, we have this clinical inertia and people are not being treated as aggressively as they should. This slide summarizes the safety information. And as we've seen in the previous randomized placebo-controlled clinical trials of inclisiran, there was no major signals about safety. The signal that you see on occasion is a little bit of an injection site reaction in the inclisiran first trial. But otherwise, in terms of other treatment emerging adverse events, there was very little difference between the inclisiran first patients and the patients in usual care. It's important to talk about the strengths and limitations of the study. So again, this is what we call a pragmatic study. So it was randomized, but it was open label. So the strengths of this type of design is that we really see what's happening in the general US population. So instead of the control group being people on a blinded drug, the control group in this study were people that are just going through clinical practice the way most people go through clinical practice. And I believe that this is a strength in that we can compare two strategies. Again, that fast and furious strategy versus the more laid back strategy that constitutes clinical care. And we can see that the more laid back strategy is not getting results even after a year. The usual care arm allowed for a lipid lower intensification by the treating physician using any means, including the use of inclisiran. So we did not exclude that for people who are in the control arm, which is something that is part of a pragmatic study, but wouldn't be allowed in a blinded study. And we also showed that the implementation strategy of the twice yearly healthcare provider administration of inclisiran early in the pathway did not affect the use of statins and really got most people to the LDL goal. So these are some of the strengths. In fairness, it's important to point out the limitations as well. And we need to understand better why people weren't using more lipid-lowering therapy in the usual care arm. Were they adequately resourced? We know that 97% of people had insurance, but did their insurance pay for advanced lipid agents? Some of those things we don't know for sure. We just know that in a variety of settings, they weren't getting these drugs for whatever reasons. The study design permitted the use of inclisiran, as I mentioned, but only 10 patients in the usual care arm ever got inclisiran, despite the fact that they knew they were in a study looking at this type of strategy. So we can look at this in two different ways. One, there would have been an even bigger difference in the 60% lowering between the inclisiran first arm and the usual care arm. It had not been for those 10 patients. But the other thing to look at is, should more patients have gotten it if we had other resources available for them? And finally, there's a good chance that in the real world, there's even a higher risk of statin discontinuation because, again, in this study, we're looking at people who are being constantly reminded about how important it is to lower their LDL cholesterol and reminded of the fact that their actual goal was either 70 or 55 milligrams per deciliter. So in conclusion, LDL lowering with a inclisiran first strategy led to sustained LDL lowering consistent with prior clinical studies of inclisiran, and most patients that were in that aggressive strategy arm achieved their LDL goal by day 330. Despite the study giving treating physicians access to LDL levels and encouraging treatment according to lipid management guidelines, few people in the usual care arm achieved guideline recommended LDL goals. To me, this was the staggering result that despite letting people know what their lipid levels are and constantly reminding them, only 7%, there was only a 7% reduction in LDL levels, and fewer than 10% reached the aggressive LDL target of 55 milligrams per deciliter. There were no new safety concerns with this study, and the results from this study demonstrate the clinical value of initiating inclisiran or another PCSK9 inhibitor early in the treatment pathway and highlighting the urgent need to improve usual care for patients with atherosclerotic cardiovascular disease. And this was a unique study, and I really want to give my congratulations to the steering committee. These are very prominent physicians throughout the United States, the 45 investigators who were the site investigators, the study staff across all sites, and most importantly, the 450 patients who participated in the study. As I mentioned, we did a simultaneous online publication of that presentation with the Journal of American College of Cardiology. And now there has been a standard publication that you can see here. And I invite you all to take a look at the paper. It's a fascinating paper. It's a unique paper. And again, shows that fast and furious strategy using inclisiran first results in much better outcomes for our patient population. So I think I'm going to now transition to the panel discussion with these questions. One, do you feel new lipid treatments are needed in India? Two, which patient types are most compelling for aggressive treatment? Three, how frequently do you diagnose patients with familial hypercholesterolemia, which is obviously a target population for people in need for usually combination therapy for lipid lowering? Four, where do you see PCSK9 inhibitors fitting into your practice? And finally, what do you consider your goals are for lipid lowering therapy? So with those questions, I'll turn it back over to the panel for further discussion.
So thank you, Dr. Koren, for elaborate discussion on Victoria Initiate. So now I would like to invite our moderator, Dr. Kamal Sharma, and our faculty, Dr. Sinha, for a panel discussion.
Fantastic talk by both the speakers. I think beautifully elucidated that inclisiran first ahead of statins is still a wise and good strategy, especially in attaining target goals and number of patients who achieve it. And very importantly, those patients who were already on statin, actually the discontinuation rate was lower if the patient was on inclisiran. So this is, this is something that actually is important in terms of translating practice, because no therapy is going to come ahead of statin unless we can design something like this. So I must congratulate the lead investigator and the team, and as you mentioned, the steering committee. My question is, recently, this is surprising though, some of my patients had concern because of the mechanism that people tout. As you already mentioned, that there is no signal on safety concerns with regards to it. But the mechanism of mRNA silencer, which is something that's been hyped around with the COVID vaccines, do you see that as a potential a risk or a confounder in translating this therapy? Because otherwise, the patients that we've initiated it on have tolerated the therapy pretty well. And I think the cost also actually comes down in the Indian perspective, because once it is to be taken twice a year compared to twice a month that we had for the other PCSK9 therapy, the cost actually becomes half. So may I have comments from both these speakers on this?
Dr. Sinha, do you want to go first?
Well, let's say even when the evolocumab made its appearance a couple of years back, there was a cost concern. And very frankly, it was quite difficult to convince the patients that you will need this injection, if not twice monthly, then at least once a month. On the contrary, we put up a fair number of patients on evolocumab, and I think around 20% of them showed a sustained response, which persisted at least till 3 months. I don't know what was specific about them, but after 3 months, again, their LDL shot up. But still, more often than not, what was happening practically in a real world situation, that the patients were dropping out and they were not coming back for a repeat injection. So I think that way, this inclisiran has a clear advantage that they don't need to be brought back within a short period of time. And by the time they can perhaps arrange their finances and sort of rejig their need for the injectable therapy, especially nowadays, the insurance and some government agencies have approved the use of inclisiran for their dependent patients. But still, that's not a great help, because the vast majority are still paying from their own pocket. So that's a concern which I believe may have been lessened with inclisiran, but has not gone away.
And I'll chime in by adding a couple of things about safety. So Dr. Sharma asked the question about safety, and people sometimes get nervous when they hear RNA or DNA, and I think it's important that we address that. So first, let everybody know that the concept of interfering RNA is something that our bodies do every day. Small interfering RNA is a Nobel Prize winning discovery, and it's actually how our bodies fight viruses. So when viruses get into our body, they're either DNA viruses or RNA viruses, and RNA viruses reproduce rapidly. And one of the ways that our body fights them is by interfering with the replication of viral RNA. And so we have mechanisms in our body and a cell organelle called the RISC complex that is actually in all of our cells that helps protect our bodies against foreign substances producing RNA. So this mechanism is part of our body. And inclisiran is a really neat molecule because it uses this GalNAc moiety, which is a sugar moiety, to target the drug specifically to the liver. The drug gets into the liver and clears out from every place else. So it's not in other parts of our body, just in the liver. And then when it gets to the liver, it is very specific for PCSK9 and really nothing else. And we know that we don't need PCSK9 to function. PCSK9 is just this protein. We're not even sure why PCSK9 is something that's in human beings, but we know that people that have high levels of it have higher cholesterol. And if you block it or get rid of it, you have much lower levels of cholesterol, and allows the LDL receptor to work much more effectively. And by silencing this gene, you're actually working in the cytoplasma, not the nucleus. So a lot of people, when they're talking about some of these technologies, and including something called antisense oligonucleotides that work in the nucleus, small interfering RNA works in the cytoplasm. It doesn't change our genes. It doesn't get into the nucleus. So that's another important safety concept. So when you think about it, this is an incredibly specific targeted therapy that uses something that our bodies already do in terms of gene silencing, and it does it in a way that focuses on a bad protein that we don't need. So to me, that's a very compelling safety case. And of course, the most important thing is we have clinical trials that show it's safe. So when we look at placebo-controlled clinical trials, like all the Orion studies that Dr. Sinha was pointing out, we see an incredibly good track record for safety and sustained efficacy, as brought up. You folks know the cost issues better in India than I would know, but these are expensive drugs. There's no question about that. And but when you look at the effect on overall cost, which is other parts of treating cardiovascular disease, there's a big offset. So again, if you having more hospitalizations with angina, more office visits for chest pain, whatever the case may be, that's a huge offset. And again, I don't even know what the price of inclisiran is in India, but in the U.S., it takes some time and effort to get insurers to approve it. Usually they do when we're persistent. And then once people are on it, we get very few people say, get me off of it. But the economics of all these things is something that physicians have to talk to their patients about, because it's going to be different for each individual patient. And we do our best to try to get access to these advanced therapies for our patients.
Yeah, beautifully answered, Dr. Koren. I think one of my patients who was semi-literate in terms of the mechanism of action, I had to counter it with saying that even the macrolides, or for that matter, quinolones that he used to pop up for every viral infection, actually interferes with the RNA. So that more with the microbial than his own, but then of course it does with the human RNA as well. So that convinced him. I think that's how I could push that therapy when he needed it the most. I'm sure we don't have enough data on head-to-head comparison, but if you could talk about how evolocumab or other QMABs, the PCSK9 inhibitors, the older generation, stand out as with the cost of inclisiran. We have a lot of meta-analysis and papers published looking at the pharmacoeconomics of it, but do we have data sets look at the outcome sets? Because we don't have head-to-head comparison between the two. We do have Odyssey and the other series for the older generation. Before Victorian Initiative could come in, I think we still are awaiting CVOT outcome trials for inclisiran. But still, if there are some data sets on the meta-analysis or case series which have looked into the outcome sets on comparison in real world setting between the two class, in comparison or as a synergistic effect, crossover kind of, if those two questions also you can answer.
Sure. Dr. Sinha, you want to give us your experience, and I'll then share some of my perspective as a clinical trialist that has been involved with all these programs. What's been your experience, Dr. Sinha, between what evolocumab and alirocumab and inclisiran?
I'm afraid we don't have that much clinical experience or that much, I would say, even discussions, because the difference in timeline was around 5 years for the evolution of evolocumab. And although there were initial hopes that the use of evolocumab will pick up like anything because it was such an effective therapy, but as I said, because of the frequency of treatment requirement and the cost, which sort of added up if you see the 3 monthly or the 6 monthly expense, even the insurance companies were not very clear in their mind as to what extent they are going to afford it or rather provide it for their patients. Because, I mean, we were asked as to what would be the possible duration, and we had to say that it had to continue for a really long time. So, I mean, really, I can't offer you any comparative thing, but Dr. Kamal really, I think, wants to know as to any data for comparison in terms of not only the short, but the long-term effectivity and any other differences.
Sure. Well, I can weigh in by saying that I've been involved with the development of all these compounds. So I was very involved with the development of both evolocumab and alirocumab. And they are, just to remind everybody, they're monoclonal antibodies that bind PCSK9 in the circulation. So PCSK9 is such an interesting molecule. It's a protein that circulates, and it binds the LDL receptor, which is on the outside of the liver facing the circulation. And for that reason, by binding the PCSK9, you get profound lowering of LDL cholesterol. In fact, it's probably the PCSK9 antibodies are probably slightly more effective than inclisiran in terms of LDL lowering. So if you put all the studies together, you see pretty routinely about a 60% reduction in LDL lowering with evolocumab and alirocumab. And that's pretty consistent. And if you look at the immediate effect, it may be even a little bit higher than 60%. The inclisiran studies across the board, when you put them all together, they're routinely around 50%. the study I just presented to you, which is the Victorian Initiate, which is, quote, real world, it's not placebo controlled. Remember, it's open label controlled. So that's a little bit different, but that was 60%, but that was the higher difference than what we saw compared to some of these others. Nonetheless, inclisiran is still extremely effective and has the advantage of being longer acting. And because inclisiran blocks the production of PCSK9 versus blocking the ability to bind extracellularly, there's some little differences in the mechanism. And we don't know how that's going to exactly play out. But so far, so good in terms of the safety of inclisiran. And most people think that this extended effect of inclisiran offsets maybe the slight difference in LDL lowering between using the antibodies and inclisiran. But again, those are clinical choices that people need to make. And then the other thing, just to talk a little bit more about some of the backlash we had in the United States when evolocumab and alirocumab hit the market related to the cost. There was a publication that came out immediately after evolocumab was approved, saying that they did not feel that evolocumab would be cost effective at the asking price for it at the time, which was $14,000 a year per patient. So there's a little bit of outrage, quite frankly, in the United States about that when that came out. And the companies did respond to that. So they've lowered the cost of both of alirocumab and evolocumab to about $7,000 to $8,000 a year per patient. And inclisiran in the United States is about the same. So there was response to that immediate. Now, that's still a lot, no question, but it was cut down compared to the original ask. And the other thing to remember for inclisiran, the recommendation is you get 3 doses the first year and then 2 doses subsequent to that. So it's going to be a little bit more expensive for the first year, and then the cost will come down during maintenance therapy. So I hope that kind of explains it. But Dr. Sharma's point is correct. There have not been head-to-head studies between the antibodies and the small interfering RNA. But when you put all the studies together, you're looking at about 50%, maybe a little bit more for inclisiran, and probably about 60% in that range for the antibodies.
I completely agree. There is enough data set which has actually showed, especially from London, which has showed that the pharmacoeconomics actually are in favor of inclisiran rather than evolocumab or alirocumab. Dr. Ray's group has done a lot of publication in that area, and he's talking about how the catching up phenomena, the rebound, etc., come in. But Dr. Michael, in India, actually, the price is lower for inclisiran as compared to alirocumab and evolocumab. It comes to half. So,
okay, well, that's a huge difference. Yeah. In the US, the first year is about the same, and then the second year there's a little price advantage to inclisiran. But the truth is, what the patients pay and what the insurers pay could be very different. So I don't know how that works in India, but you never know. I prescribe these drugs, and somebody will say, "Oh, doctor, I can't believe it. You're making me pay $500 a month." And then I'll have other patients come in, "Oh, that was great. I don't have to pay anything." So the insurers pick up things in a very variable way in the US.
Yeah, absolutely. Dr. Sinha, one more clinically relevant question we all face day in and day out. In India, we have bempedoic acid, ezetimibe, and statins, which are pretty cheap. And we know ezetimibe, of course, gets a class 1 indication, but bempedoic doesn't. Now, with the clear outcome trials coming in, the tendency amongst physicians and sometimes in patients to supersede an oral therapy over an injectable one tends to have patient put on a combo of bempedoic plus ezetimibe plus statin rather than being prescribed a PCSK9. Your thoughts on that? And of course, the science behind it or lack of science behind it, to be more precise.
Actually, Dr. Kamal, it should not be said to be a lack of science. It has to be a practical approach. We are dealing with the patients. They are our responsibility, and we are responsible to them. Now, as you said, there is a unwritten rule, I would say, that you avoid costly therapies and you avoid injectable therapies. I mean, nobody would like to go for a very costly therapy right from the word go. But yes, just before the webinar, I was thinking and drawing out some subgroups as to where exactly I would like to use inclisiran in the first group. So I think on the top comes the homozygous or the heterozygous familial things. I know they are not common, but let's say if you are having a third eye for that, you find out such patients. They are not that uncommon also. Every 6 months or so, we come across a family with those large xanthomas and all of them having a brain or this heart attack, etc. So that is one group. The second group, I would say, is those who are non-compliant, careless, those perhaps despite their good intentions, although I would doubt that, but they are still non-compliant. So how to go about it? If they can afford, give them inclisiran and obviously add a statin, and perhaps they will realize that if they want to cut down the cost, they have to be compliant. Then that may be a starting point. I'm not so sure, but perhaps I would say very high LDL on the baseline, even if the patient is a sporadic, not a heterozygous or a homozygous carrier. So high LDL, for example, if anybody is coming to me with an LDL of 160, 170, asymptomatic, then obviously they need to be investigated. But if there is an ACS or something, then I think I would like to advocate the injectable therapy initially. Now, regarding the ezetimibe and statin, it's my practice has changed over the last 4 or 5 years that I'm using ezetimibe very, very liberally. And that's also because a lot of combinations have come in the market, which have, I would say, a reasonably priced high dose statin plus ezetimibe. Bempedoic acid has been discussed in many platforms, but between you and me, I don't think it has made that much of an impact. And even if I scan my records of maybe 200-300 patients where we may have used bempedoic acid, there won't be more than a handful where it worked what it was really going to do, or what we thought it was going to do. Ezetimibe, yes, I'm using it quite frequently. Statin intolerance, again, will be one thing where you really can't take chances. And even if you try and reduce the dose, sort of re-challenge them, give them some other medications, that's probably not worth it because you are not going to achieve the low LDL that you want. So these are some division of subgroups which I was thinking and I had put down on a piece of paper, and I would really love Dr. Koren's comments and after yours. Yeah.
Sure. I have a quick question for you folks. Is bempedoic acid expensive in India?
Not at all.
Yeah. Okay. Interesting. Because in the United States, bempedoic acid costs just as much as the PCSK9 inhibitors on a yearly basis.
Okay. So Dr.
cost is
Koren,
not an
actually,
advantage.
because
That's news
it's an
to me.
off-patent product. It's an off-patent product. So biosimilars actually come in pretty cheap in India. So, India is a big biosimilar market. So
Sure.
the manufacturing for bempedoic is much cheaper. And because it's off-patent, so there's flooding with a lot of generics, actually. And that's the reason it's as priced as much as a statin, not probably more high-dose statin. And that's
I
the
might have to
reason.
send some of my patients to India for it. But yeah, but it's a very expensive drug. Actually, it costs just as much as the PCSK9 inhibitors
So
in the US.
So in India, the Lipid Association of India actually touts it as the third step in choosing as a therapy, probably because more so with the cost than with the guidelines or outcomes, except the clear outcome trials, where it was primarily driven by a statin intolerant subgroup of patients.
Right.
But I think that, what Dr. Sinha mentioned, the three important indications where I would be very aggressive in using inclisiran. The third patient subgroup would be a heterozygous, may not be homozygous, but has got recurrent events. Now that's like combining two events, two indications in one. Both of them are class 2. But when you have recurrent CV events on high dose statins, and you also have heterozygous, that again is something that I usually choose to add inclisiran on top of high dose statin. So those are the some subgroups which I often discuss. One, he mentioned homozygous. Second is somebody who's intolerant. And third is the recurrent events despite on statins, even if he's not homozygous.
Right. Now, I tend to use a mathematical approach, and let me explain what that means. So let's say a typical patient comes in, they're 6-month post-acute coronary syndrome, they're on their high dose of statins, their LDL is 100. That patient has to get down to 50 in my book. And so using ezetimibe alone will get them 15% lower. Using bempedoic acid alone is going to get them maybe 25% lower. We have a combination product here. I don't know if you have that combination of ezetimibe and bempedoic acid. You'll get maybe 35%, but that person needs to get 50% or more lower. So why mess around with those other things when I know I'm not going to get to my destination? So that patient needs a PCSK9 antibody or inclisiran in my book. So that person would get an advanced therapy. So I look at the numbers quite a bit. Now, if that same patient came in and their LDL was 75, then I might try those other things because they're closer to their target. So I use that concept quite a bit. And again, I agree with you. I've been an investigator in the CLEAR Outcome study, and that was a funny population because it had a lot of statin intolerant patients. But so I consider that actually. And if somebody comes in and they can't be on statins, I'll try bempedoic acid as quote their base drug and see if that works. And then always have the option to add a PCSK9 drug on top of that. And then you alluded to the ezetimibe data, which was the IMPROVE-IT study and another study that was shown to prognostic benefit. But the point of that, which is really important for the audience to understand, is that everything that seems to lower LDL seems to have good results as long as there's no offsetting problem with the drug. And we're not identifying any offsetting problem with inclisiran. So there's no reason not to believe that LDL lowering won't result in benefits to the patients.
Fantastic. I think we overshot time by 15 minutes. I think we can have quick closing comments from both the speakers, and then I can hand it over to the moderator. First, Dr. Michael Koren, your closing comments.
Well, again, thank you for inviting me. And as you can see, based on my experience in India about doing things in a fast and furious way, I endorse that. And I would hopefully the audience would look at some of our recommendations and use this approach to help their patients. And that's what I preach here in the US. And hopefully we can get that message across India.
Dr. Nakul Sinha, sir?
Well, nothing new to say, but just a very practical point for our listeners that please avoid the calculated LDL in the reports, which are there mostly. That may be a trap where we are not really seeing the direct LDL measurement. So that is one thing I always bring up in one way or the other. I think that's important because then you may be missing the boat.
Perfect. So over to Team Lupin. Dr. Pradeep, you want to take over?
Thank you. It's indeed very wonderful discussions and reaching each and every aspects related to the inclisiran and place of inclisiran as well as dyslipidemia management in India as well. So I invite Mr. Anuvai to say a vote of thanks to our esteemed speaker, faculty moderator, as well as our audience. So over to you, Anuvai.
Thank you so much, Doctor. On behalf of Team Lupin, I would like to thank Dr. Sinha, Dr. Sharma, and Dr. Koren for this fantastic scientific feast, which we all enjoyed in the last few minutes. And I'm sure the points which have been discussed and the way we have put forward the advantages of inclisiran will definitely help a lot of physicians across India to accept this molecule and in return will benefit the patients in India. Thank you so much, sir, for your valuable time. Thank you, sir.
Thank you.
Pleasure.
Good night.
Bye-bye, everybody.
Dr. Koren, thank you, Dr. Sharma, Dr. Sinha.